Next, we move on to the keynote session titled Modern Management of Penetrating Injuries. This important session will be chaired by the Senior Consultant Surgeon, Dr. Kirthi Abejeeva, and the Director of Accident and Orthopedic Services of National Hospital Sri Lanka, Dr. Indika Jagoda. The keynote speaker is none other than our guest of honor, Professor Sharmila Dissanaike, an eminent surgical educator and trauma specialist in USA. I warmly invite Dr. Kirthi Abejeeva to introduce the keynote speaker.
May I invite Professor Sharmila to the podium? It's a difficult task to say what, to decide what to say. It's a so huge CV, so we have sort of shortened it very brief, I would have missed a lot of things, but she is at the moment the chair of the surgery at University of New Mexico, formerly Peter C. Shinsario Chair, University Distinguished Professor at the Texas Tech University. She's clinically active, a trauma surgeon and a burn specialist, an acute care surgeon, and also a researcher. She's a national academic sort of surgeon leader with multiple leadership roles in American College of Surgeons, American Burns Association. In fact, she was the immediate past president of the American Burns Association, and Southwest Surgical and other national and regional societies. She's also in the board of directors for publicity and listed biotechnology films. May I invite Professor Sharmila for her keynote address.
All right. How do I advance slides? Is this, am I using this? Okay. All right. Okay. So I'll try not to mess up the mic this time. Good morning. So I wanted to talk about something that hopefully I can add value to a room that's already full of trauma experts. And one of the interesting things about being in the United States and in the state of New Mexico where I publish is that we're one of the few countries in the world, definitely one of the few high-income countries in the world, where we have more penetrating injuries handled by civilians than our military surgeons do. Interestingly, military surgeons in the United States train at major level 1 trauma centers like mine to get readiness for what they call battle ready, readiness for handling the bullet wounds seen in military injuries, because unfortunately, due to gun restrictions or the lack thereof, we very much see military grade injuries in the civilian world. This is a graph showing you the number of firearm deaths in New Mexico per year. I want you to also remember that in my hospital, for example, the mortality from firearms that get to my level 1 trauma center is only 6%. So if you think about that, this number that you can see is easily over 500 is those who either died at the scene or that small 6% that died after they got into the system. That gives you an idea of how many penetrating injuries we see. I see in my center at least 1 gunshot every single day. And it's very few places outside the US that have that kind of frequency in civilian practice. On a busy summer, we can see 6 to 7 separate gunshot injuries in one day. In Chicago, South Side, I think the record from my friends at the University of Chicago is something like 25. So it is really a problem. If you notice back in, let me see, about 2015, 16, if you look at that graph, a very interesting phenomenon happened. And gunshots exceed car injuries as fatalities in New Mexico, and interestingly in the entire United States. So we're one of the few countries where more children die from gunshots than from car injuries. This is a statistic I do not think is replicated anywhere else in the world outside of a war zone. And so penetrating trauma is something we know a lot about. And I figured I would share it with those fortunate enough not to live in a place where so many people get shot all the time. So 3 major things I wanted to talk about: a paradigm shift in resuscitation, tourniquet use, and then non-operative treatment of penetrating injuries. And so let's tackle those 3 topics because I think they've evolved really over the last 5 years. I'll say the non-operative treatment in the United States has been quite popular for about 10 years, and the other 2 are a little more recent. So the first topic, should we do CAB instead of ABC? So right now, all of you are familiar, I'm sure, with ATLS, right? We're having a little course session in parallel, and everyone knows the airway breathing circulation. Can anyone in the room volunteer bravely to put their hand up and tell me why we decided on ABCs? Okay, who thinks it was based on evidence-based review of the literature? Hands up. Who thinks that we picked ABCs for that reason? Okay, no hands. A few hands. Good job. We got some brave people in that corner there. Okay, who thinks it was because ABC sounds like it's with the alphabet and it's easy to remember? Okay, an even braver person there. Good job. I actually think that's likely the answer because truthfully, nobody knows. There's literally never been a discussion of how we came up with ABCs. ATLS was created a very long time ago, and we just started that way, and then we just continued, and no one asked the question why. And I really think it's because it's easy to remember, not based on any data. So why change? Well, the reason I think we should change, so there's 3 good reasons, and hopefully I'll convince you through one of the 3. So one of the 3 is that in the military, where arguably they do consistently see higher amounts of bleeding injury, they have used CAB for a long time. So this particular slide is from a British battlefield journal. This one's from the United States. They just, to be difficult, they had to create their own list of acronyms. I will tell you, I don't think there's a group in the world that has more alphabet soup than when you deal with US military organizations. There's so many things. So they go to March instead of ABC, but they started with bleeding, and this is from the Department of Defense, a slide actually from quite a few years ago, nearly 10 years ago now. So the military has been doing circulation before airway for a long time. And there is data. So when I started and I asked you all, do you think there's evidence? Pretty much nobody did. There is evidence that if you look after the airway and you intubate a patient, before you actually fix the fact that they're bleeding to death, they do worse. We do have data. Look at the date on this. This is 2005, guys. This is not new. And this study showed at the time that if you did this before the hospital, if the EMS intubated the patient, there was increased mortality, reduced survival. This was also looked at in a meta-analysis. You'll see some of the names come up here in a second. We'll talk a little bit more. Paula Ferrada first authored this meta-analysis from 2019, and it showed the difference in mortality. And look at those numbers. So you've got, let's see, 33 to 19%, quite significant, right? If I told you that one intervention could improve your survival by 10%, absolute numbers, that would be huge. If it was a drug, everybody would be taking the drug. And so we have shown that there is actually a mortality harm or a survival harm if you intubate first. Juan Duchesne, he's actually since published this, but this is from the slide he presented at AAST in 2022, took it further. He looked at emergency department intubation, not in the field, which I know in a lot of countries they don't intubate in the field, they do in the United States, but everyone intubates in the ER, and they showed that if you did it in a hypotensive bleeding patient, you basically increase their death rate. So we have data showing that it's probably ABCs may not be the right thing in everyone. Paula then went on to lead a multi-center trial, international trial through EAST, and she found, again, the same thing. The 24-hour mortality, which is your standard predictor of bleeding trauma, bleeding death, was lower in the group that had CAB. So we do have data that it's probably the right thing to do. I'm a very simple person. I like common sense. How many of you in this room have treated an airway injury that caused the patient to collapse? They couldn't breathe because of an airway injury. Hands up. I mean, I have. Okay, so there we go, a few. How many of you have treated someone who was having severe bleeding from trauma? Oh, come on, I know it's more than that, right? Either way, a lot more, right? You're much more likely to die from bleeding than airway injury. I mean, the odds of someone managing to shoot you exactly in the trachea is actually quite low. It happens, but it's not that common. And so statistically, it makes no sense to me that in this cohort, we're worrying about the airway more than we are about bleeding. And then finally, there is pathophysiology. And again, I like basic principles. How many anesthesiologists in the room? Anyone? Okay, a few. So you know that the medications you give cause vasodilation in general, right? And so it makes sense that if you're using drugs to intubate, you are going to drop their blood pressure from vasodilation. And when you have no blood in your blood vessels and then you dilate your blood vessels, what happens? You have cardiac arrest. Who here has been in the emergency room and watched them intubate a bleeding patient and had the patient code? Because I can tell you I've had that happen way more times than I like. It doesn't happen now because I don't let that happen, that particular scenario, but in my training, I saw this over and over again. That, that intubate a patient who was clearly hemorrhaging, and before you know it, we're cracking their chest open because now they're coding. And if you can get them through the anesthetic intubation vasodilation, you start positive pressure, right? That's how we ventilate people. And obviously that's going to impede your venous return. So to me, it just doesn't make sense. And guess what? I'm not alone. This was another study that Paula led, and you'll see why I mention her name so much here in a second. But she did a study through AAST looking at 12 major level 1 trauma centers. And even though I can promise you every one of those trauma center directors and surgeons is busy teaching ATLS at some point, and we all teach ABC because that's what we're doing with ATLS, what they do in real life is actually not that. About half of them start resuscitating before intubation anyway, because we know it's the right thing for the patient. So even the people teaching the courses are truly doing something different because they're using their clinical judgment to adjust. So I mentioned Paula. I love Paula, she's a good friend of mine. And a few years ago I said, Paula, let me help you get this message out, because it was driving me up the wall that we know what the right thing to do is. We're doing the right things in our own centers, and then we run around and just tell everyone else ABC, and we're not actually teaching people the right thing, in my opinion. So we kind of joined forces a little bit, and we started talking about this more, because I'm a firm believer that if you're only ever publishing in scientific journals and you don't just get out there and talk to people, nobody knows, nobody cares, nothing changes. So we started publishing, and I did some videos with General Surgery News. General Surgery News is a tabloid paper run on advertising that goes to every single registered surgeon and surgery resident in the United States. It's probably what they read when they're in the bathroom. So it gets read, people read it, and by putting it there instead of a famous fancy journal, I was wanting to make sure that the message started to spread, and it did. I have probably had more people approach me about this series of articles we did than about a lot of my actual publications. But we put some real publications too. So in JAMA Surgery, we wrote an opinion piece that we really need to start acting on the evidence and not just publishing more papers. We then did a nice little literature review. We pulled in some more big names, because big names do help spread the word. David Feliciano, who sadly passed away almost a year ago now, is one of the big names in trauma across the world and in the United States. And we started really amplifying this message because we felt there's enough literature. We just need to talk more about it. And we just came up with this algorithm that I think is really quite a nice guide for the trauma patient in what you do if you have incompressible or non-compressible hemorrhage and how to prioritize. And I'm happy to share these articles with anyone afterward and send them to you and send PDFs if that's helpful. I think the times are changing. High-level trauma centers are already doing this. Some of us call it CAB, others call it ATLS, which just doesn't roll off the tongue as well for me. But I think that in tandem with focuses on whole blood, which is a whole nother topic, balanced resuscitation, we are learning to prioritize circulation. And so the take home I would love you all to take is that it's okay to deviate if a patient's bleeding and address that first. So the next topic I wanted to tackle is tourniquets. So who here, you've already learned, I like show of hands, I like to wake people up a little. Who here has applied or removed a tourniquet in the last, 6 months? Okay, so about maybe a quarter of the room. Okay, who here has ever applied a tourniquet or taken it off? Okay, so not very many people, right? And so that's interesting to me. This slide comes from Australia, where they're trying to educate people in first aid on tourniquets. I can tell you, this would not have existed when I was training. So I'm not that old, a little old now. By trauma standards, I'm practically geriatric. But when I trained, I was told, oh, we don't do tourniquets. People's eyes are going to drop off, right? Don't use tourniquets. I was definitely explicitly told that. And yet, we have now started to show that that is not the case. And much like a lot of things, it comes from the military. Trauma care, I firmly believe, advances in war and then usually tracks back to civilians. And in the military, in the United States at least, there started to be a lot of buzz about tourniquets that then help transmit to civilians. So we did this study in the Texas trauma system, looking at civilian pre-hospital tourniquet use, training EMTs to put it on. And we actually showed that it increased survival. If you look at the mortality number, it's quite significant, 5.2 versus 3.9. And it did not result in a higher rate of amputation. That was really important because most of us have been fed the dogma that if you put a tourniquet, you're going to be chopping their arm or leg off any minute. And that's not really true. Now, with a tourniquet, it is important that it's put on correctly, and I'm going to pause for a second. So, one thing I still see in a complex, evolved trauma system like the United States is tourniquets not placed properly. And the biggest mistake I see is people tend to put the tourniquet in the same place. So if it's the arm, they'll put it up here, and if it's the leg, they'll put it on the thigh. And what's wrong with that? I know there are trainees here from the National Hospital. Someone tell me what's the best place to put a tourniquet. Your boss is here. He's going to be very embarrassed if nobody answers the question. If someone is injured in the calf, where should you put the tourniquet? I don't know, in the calf. All right. No one's going to volunteer? I'm not going to ask the front row foreign dignitaries. I know they know. Okay, so the right place to do it is right above the injury. Okay, it's not on the thigh. You want the tourniquet as close to the injury as possible. And that should be the goal of what we teach people if we're going to promote tourniquet use. If you put it up on the thigh, it's not terrible, but it's not nearly as effective. And that's the number one mistake I see in the United States when I'm working with EMS. And so they looked actually at functional outcomes. Vanessa Hose from Metro Health in Cleveland, their team did a nice study, and they actually looked at patients who had tourniquets, in fact, had higher function in addition to better survival. And this was a systematic review done by a group out of China, and they found that it led to decreased mortality, as you might expect. So there's really good evidence that tourniquets should be used. This is a slide from Stop the Bleed. That's one of the most successful programs we've done at the American College of Surgeons. The gentleman shaking the hand of President Joe Biden is Len Jacobs. Lenworth Jacobs. He's a phenomenal trauma surgeon, wonderful human being. He was in Hartford, Connecticut, when the Sandy Hook shooting occurred in the United States, the first mass shooting in the United States where it was mainly children and little children who were killed. And he basically used that to spur a group of politicians and medical leaders, as you can see in the picture there, to create a program to help civilians respond to this kind of catastrophe. Now, I personally would prefer that we just didn't have so many mass school shootings. That would be even better. But if one must, then training bystanders in Stop the Bleed is at least some way to help save lives. In the United States, politically, as you may or may not know, trying to get regulations on firearms is highly contentious, which can seem strange to a lot of people outside the United States. It still seems a little strange to me. And so rather than focus on that, focusing on stop the bleed training in schools, in hospitals, in all public places has been very successful. So right now my trauma team at UNM regularly goes out and teaches stop the bleed in schools as a way to try to help bystanders respond better. So on to the final part of the three-part controversies I wanted to tackle. What do you do in this kind of penetrating trauma? So you can see some omentum kind of sticking out. It's a stab wound. Who here would automatically operate on this patient? Okay, so we've got 1, 2, all right, so about 3 or 4 people. So that means that the vast majority would not operate? Really? Okay, so let's talk a little bit about whether we're just being shy to raise our hands or whether there's really something here. So the reason I show pictures of me with some of these people is to actually highlight a key point, which is collaboration and communication between trauma surgeons, which is one reason I'm so incredibly honored and happy to be here today. That's Kenji Inaba from University of Southern California, absolute wonderful human being, great friend, one of the few trauma surgeons who's also a fully trained SWAT police officer. There are 2, him and Alex Eastman. Kenji was part of the group, interestingly, who has transported some fairly high, since he's in California, celebrity prisoners back and forth by planes. He has a lot of great stories, but he's also an incredibly prolific researcher, and one of the things he's worked on for the last 10 years is non-operative management of penetrating injury. And one of the things that they found in a series that was heavily skewed to gunshots, I highlighted that 70% of his penetrating injury is gunshot wounds, so a really high acuity series, and they still found that they could manage a substantial amount of the trauma patients without operating. This kind of data tends to come from 2 countries mostly, South Africa and the United States, because we have so many penetrating traumas that we end up having to triage, and that's actually what what created a lot of this data in Johannesburg, long before the United States jumped on, about 2 decades ago. They were having to triage and develop algorithms simply to manage the volume, and that's how we started to realize you could safely manage these patients. What's really important, they had 3 patients who failed non-operative treatment and ended up having to go to the OR, but they didn't suffer complications from the delay, right? Like the fact that they didn't go straight to the OR did not hurt those patients, and I think that's really important. A series from the Netherlands, because I chose this one to show that you don't have to be in a high volume penetrating trauma center to do this safely. In this Dutch study, they created this algorithm looking at obviously ruling out hemodynamic instability and evisceration, and then trying to see who they could safely manage. I'm not going to go into this in too much time, but they basically found that it did not harm their patients. What's a little disappointing is in the Dutch study, they still had a fairly high rate of non-therapeutic laparotomy. The problem with non-therapeutic laparotomy, does anyone want to tell me what the problem with that is? Why does it matter if you do a laparotomy and it's negative? What's the downside for the patient? Okay, maybe it's just too big a room. I'm not getting audience participation here. But the problem that we see is that it causes hernias, it causes adhesions, it makes the operations harder, and it's this big whopping incision that they have to recover from, right? And so there's actually a lot of downside, in my view, to operating for no reason on these patients. And this study did not show it, but others have. So I just wanted to finish by running through these practice guidelines for selective non-operative treatment of trauma. These are actually from 2010, came out through the AAST primarily, with some other organizations participating. So I've tried to highlight the important parts. They have to be hemodynamically stable, and they have to be able to have a reliable clinical exam. If you don't have those 2 things, it doesn't work. So you have to have someone you can examine and who's stable. You definitely should consider it in stab wounds. If a gunshot goes in the front and out the back, you probably should go ahead and operate. But if it's a tangential injury based on the trajectory of the bullet wounds, that's probably a good patient to consider. Serial physical exam is reliable. I don't even always scan these. In the United States, we joke that like we should just put the CT scanner at the front door and just wheel people right through it because everyone ends up getting a scan. So I will tell you it's rare for us to manage these without a CT scan, but it can be done in a patient who can be examined reliably. However, for the most part, most of us use an abdominopelvic CT. It works particularly well in the right upper quadrant. Why? Because the liver's right there, right? So if it's above the liver, odds are you're going to do great managing that patient non-operatively. So just bear that in mind, that right upper quadrant wounds, this works really well. You want to keep them in for 24 hours. I didn't pull up the source literature for this, but it was a study that was done, and I can't remember where right now. But they found that the vast majority of patients get peritonitis in 12 hours if you don't operate and they have an injury. But about 3 or 4 patients will only present close to the 24-hour mark if you have enough patients. So I always mandate in our center that they keep them for 24 hours before sending them home if we're going to do non-operatively. And then if the stab wound or the gunshot may go across the diaphragm, I will always put a camera in and do a diagnostic laparoscopy. Because if you have a diaphragm injury, it's really easy to fix laparoscopically for the most part. If you wait and let them come back with this massive diaphragm hernia, that patient is going to need a much bigger operation. So if you're worried about the diaphragm, that doesn't show up well on CT, I will typically put a camera and have a look. So in conclusion, I would encourage us to consider early institution of resuscitation with blood, especially in a CAB approach, especially in penetrating injury patients. Even blunt is okay, but in anyone you think has bleeding as the cause of their instability. I think we need to advocate for appropriate tourniquet use in our pre-hospital setting. That will require some resources and investment and training for our EMTs, but I do think that will be life-saving and limb-saving. One of the other major shootings that happened in the United States was the Pulse nightclub shooting in Orlando. And when I looked into that a little bit, one of the people who died was a 18-year-old girl. She died of a brachial artery bullet wound. She bled to death from an injury that someone could have stopped with 2 fingers, basically. And so lack of public education on bleeding control and tourniquet use is a problem, so I think it's up to all of us to improve that. And then finally, if you have a stable patient with no peritoneal signs, you really should consider trying some non-operative management in trauma. Thank you all very much. It's been a great honor to be here.